Next on the list, we have Dr. Kruze, who is an ultrasound expert and a burgeoning Transosseous maven as well in terms of technology. So Kevin, you want to go ahead and you should be able to share your screen, hopefully.
All right. So thank you very much, Brett, for having me on. It's pretty cool to be able to do these types of things. I think this is definitely one of like the advantages of COVID, that we realize like, hey, we don't need to fly to different places to have meetings like this. And it's still fun to go to meetings, but it's really easy to do this, you know? So awesome. Thanks for putting it together. Pretty cool. So Brett asked me to talk about a couple things today. I'm a huge ultrasound guy. I love ultrasound. I think it's amazing. I think it definitely cuts to a lot of the things that Brett's trying to do with his company, his technique, and Transosseous. So I implore all of you to get involved with ultrasound if you can. And then also, so looking at the ultrasound evaluations, which I've done in my career, and then also looking at pain after rotator, or pain after the repair, which I've looked at some of my SOS data, and then also looking at what I call the poor man's SCR. So, and by the way, this is my contact if anybody wants to look at that. Sorry for that typo in there. I don't know how I missed that. But yeah, if you guys ever want to email me, anybody want to give me a call about anything today, just hit me up. All right, so main points today is this going to be transosseous repair as superior biology and biomechanics compared to transosseous equivalent. And there's been some pretty elegant studies in the Japanese data that have shown this. And I actually went to Japan and talked to a lot of the guys there. I went there to actually meet Chiru Mahata, but one of the serendipitous parts of that trip was meeting with a lot of like the really, really high-end orthopedic surgeons looking at ultrasound, looking at elastography, and looking at the biology and the biomechanics of cuff repair. So the Japanese are really, they're way ahead of us on terms of that curve. Looking at SCR, looking at the cost of SCR and how can you decrease that, and some of the things that I've done. And then also looking at pain from a Transosseous technique, and what I found with looking at my own data, comparing tunnels versus anchors. And also I have a device that I was going to show you guys that I didn't know if it was going to come, but it's basically like an augment for making Transosseous a little bit quicker. So looking at the biology and the biomechanics, I think everybody that's spoken today has looked at this. And so this is one of the, you know, looking at the Japanese data, and this is some of the images from some of the papers that I pulled that they had. There's a guy named Itoi Gawa, who's a really, he's written some really good articles in arthroscopy looking at elastography for ultrasound and being able to basically use that as opposed to Goutallier for looking at the elastic qualities of the cuff, can be repaired or not. But what they found when they looked at the elastic, when they looked at the vascularity of the cuff, when they used ultrasound to actually measure the vascularity, is that they had much more vascularity at the interface of the cuff throughout the repair process with Transosseous techniques versus using like a speed bridge construct, which I think we've all talked about. So, you know, with the speed bridge, it's, I always tell people it's kind of like, you know, if you fix a femur, right, you can nail a femur and it's going to heal. Okay. You could also take a femur, you could nail it, then you could open up the leg, strip off the periosteum, and put on 3 locking plates, right? So there's a limit to the biomechanics and how far you need to go from a strength standpoint to get what we need to have done. And there is the law of diminishing returns. And I think, you know, some of the constructs like the speed bridge and some of these other knotless repair techniques, it's just too tight. And we did a study when I was in Greenville with Dr. Hawkins, looking at the vascularity of the cuff with double O's and how you could easily overtension the cuff to cut off the blood supply. But they also looked at the modulus elasticity. Some of the Japanese papers, they weren't able to get them to me by this talk, but they basically show that you create this interface of very stiff construct with something that's very unstiff, which is the mild tendinous junction of the cuff, and it's a recipe for failures. And so this is one of my cuffs. It was interesting. Brett, I was like, man, I ultrasound my cuffs, but I got to look back and see. I had a guy come in. He was 2.5 months out. This is a transosseous repair, and he fell. He hit his arm on a door. I was like, oh, this is beautiful. On Thursday, I'm going to show this. So this is just a quick video looking at the transosseous repair, and I would call this a Sugai 1. I mean, that to me looks like a beautiful tendon interface. You can see the tendon very clearly. I haven't gone to the level of like med vascularity on my cuffs through the process and looking at the difference. It's very subjective to try to do that with ultrasound, but you do know when you do measure it, and the Japanese papers have shown this, that you get more vascularity from time 0 up until a healed cuff when you use bone tunnels versus ankle repairs. Just another one here. You can see the sutures through it beautifully. So this is, if you guys don't use ultrasound, it's amazing. Someone falls, they hurt their shoulder, just put the probe on there. You can show that the tendon's healed. Just be careful, because a lot of the patients that are doing okay, and you ultrasound a lot of them, you're gonna realize your failures are a little bit more than you'd like to accept. So looking at SCR, so I actually did this technique. This is like the first surgery that I did in practice. I know that's insane, but I had a buddy of mine. We came in together 5 years ago in Dallas, and he had just gotten back from Vail with Peter Millett. And so this is like right at the beginning of when it started taking off. And I had my partners just sent me all these massive cuffs when I got there because they wanted to do reverses. And I was like, I don't want to do a reverse on someone that's got full range of motion, no arthritis, and just a functional cuff tear. So I'm like, I don't know. I do a reverse on that patient. And so I flew to Vail, learned how to do the technique, and then came back, and it was my second case. And so we did an SCR on this patient, and it was like a total home run. And I remember afterward, I was eating dinner with my family, and I was pretty proud of myself, like, that I had the audacity to do a case like that, and it worked out so well that early in practice. And one of the reps accidentally texted me when they were trying to text one of the other reps that I had spent like $12,000 on the case. It was like Kruze spent $12,000 a day. I used like 8 anchors, grab, biceps, subscap, the whole thing. I mean, I was just like, and I just kind of shrugged it off because I was like, okay, whatever, who cares? And then later on, I realized I was a Medicare patient. So like, and that's our surgeon-owned hospital I did that at. So we just totally ate that whole DRG. So that's just a total lose for us. So I've been thinking, I started looking at the numbers more at our center and trying to be more of a value-based guy. And I've talking to Brett since I was a fellow about using the tunneler more. And so and when the SR started coming out, I always asked, like, why we took this very new technique, right? That's like a totally revolutionary thing, a way to treat cuffs, and everybody's all excited about it. And then we just like all of a sudden start using allografts because, Alan Hirahara and, Chris Adams at Arthric says you can use an allograft. I'm like, well, you can use an allograft for anything, but we're in like a really poor biological environment, right? And we take a guy who's done literally 500 and done 5 years, right? So Turu Mahata had done 500 at 5 years. And we say, we're just gonna use allograft and see how it goes. And I was like, why aren't we doing TFL? So I flew to Japan and I watched him for a week do them. And so I came back and I was like, dude, I can do an SCR with a tunneler, 2 corkscrew anchors immediately, which Mahata, believe it or not, this is what he does in the glenoid. He does 2 old school 4-5 corkscrew anchors, double loaded sutures, passes all 8 limbs, ties 4 knots. That's how he fixes it. And then he does a speed bridge laterally because he's like an Arthrex guy. But you can easily do a bone tunneler laterally. And so I did a couple of these. I did like 10 when I came back. And it was kind of a beating because I'm a beach chair guy and he's a lateral guy. And he has, in Japan, it's interesting, like you don't get to become an orthopedic surgeon until you've been like a junior professor for like 6 years. So he has this guy who scrubs with him every case who's an orthopedic surgeon. And all he does is get the graft and make the graft. And they're lateral. So he's doing this while I'm trying to get the graft with one of my partners. And it was kind of a cluster. And actually had 2 of them get a P. acnes infection, right? And Mahata actually had that happen at the beginning of his practice too. He started putting IOBAN on the shoulder and changing some things, which I had never had an infection from a scope before. So that's why I was like, oh, I don't know if I want to keep doing this. And so what I've switched to doing now is I use the MTF allograft, which is the cheapest allograft you can get on the market. I double stack it and I weave it with tape. And I just use 25 millimeters because I don't want to pay for an extra allograft. And I double stack it. So the graft is actually 5x5. And so you double stack it. I look at it like an ACL, like I'm just trying to create a bridge. And then I use tunnels and just 2 anchors. So, I'm spending $1,000, but it's a lot better than 12. But Mahato's an awesome guy, by the way. Like I don't think he's fudging his data at all. I think he's a really honest dude. And so these are some of the pictures of these bone tunnel SCRs with TFL. And it's interesting because when I went into the Arthrex database, SOS is amazing, by the way, if you don't use it. I know that we're kind of anti-anchors here and all that stuff, but SOS is, I've used it since I started practice. I love it. But when I type in fascia lata as the graft and you search the Arthrex database, there's one other tensor fascia lata graft that has been done in the United States other than yours truly. It was weird to me. I was like, that's so strange. Like, why isn't anybody doing this? And it's just, it takes a long time and it's really hard. And so I think I think it's awesome because it's biologic, it's free, right? Which is amazing. But just from a time standpoint and a setup, it depends on how you scope and you can do it from a beach chair, but it's just hard to get down there low enough. I think if you're a lateral scoper, it's a lot easier, but even then, it's just tough. It's just tough. So this is another one that I did. And these patients all did really well, by the way. The ones that did not get infected did great. Even the guys that did infected did well. I cleaned them out and just kept the graft. So yeah, just 2 double-loaded corkscrew 4.5s in the glenoid. You can use Parkus anchors, something really cheap. And so you can take this from something that costs $10,000 when you account for the speed bridge laterally. Arthrex always has 3 anchors on all their talks immediately, and they want you to use the knotless fiber tacks, right? Because that's the newest widget. Those are $600. But you can just do two anchors immediately, double loaded. And Teru Mahata does this on Japanese patients, right? So these are small people, and he's doing 4 or 5 anchors immediately, but it's unbelievably strong. And he's never had a fracture. He's been doing it from day one. And the chance to do a lot cheaper anchors for some of your more value-based products. And then just do bone tunnels laterally. And then I use an allograft now just because it was easier, but I've used a much cheaper allograft. Arthrex charges $4,000 for their allograft, which I think is insane. And so, Brad, I pulled my data. It's interesting because if you look at this, you're like, oh, well, you're starting higher. So this is like something that I pulled this week. But the one I do a hybrid technique. And so if I were to go in and really look closely at my data, back when I was using 4-5 swivel locks on the medial row, the pain score was actually, it was like 1.5 different. I think one of the reasons why this data, so the blue is transosseous and the red is anchors, right? So you say, well, the curve's a little bit steeper and you're lower, but you started higher. I think since I use all suture anchors on the medial row when I do use anchors, that it skews this data because I don't think that medial row all suture anchors hurt as much because it's such a small footprint in the bone. But a 4 or 5 corkscrew in the subchondral bone on that medial row, I think that's unbelievably, I think that causes a lot more pain in the shoulder. And I also think having tapes because of how much you overtension the cuff does. So when I looked at my data, when I was looking at true like plastic peak anchors on the medial row, it was a significant difference at the pain score. And there was the Italians actually showed that one of their studies at when they did the randomized trial, they showed 2-week and 6-week VS pain scores are definitely lower. And that's all I got for that. So I don't know if you guys have any questions. So one thing I wanted to show you guys, and I asked Brett if this is okay. I'm not trying to be like a salesman here, but so I love doing bone tunnels. I also love to be really, really efficient with my operations. And I will say for me, like taking a single row anchor and just passing 4 to 6 limbs from a triple loaded into like a lateral anchor, I can do that faster than I can do a transosseous repair because I'm just not tying knots. And so I've been thinking for a while about creating a device where you basically are just linking the sutures from your medial lateral row with a clipping device, and also would allow you to tension them all at the same time. And so it actually just came in, and I'll share with you guys a little PowerPoint here of the device. So just looking at the device, it's essentially a clip where there's a male and a female end, and I actually have one right here. You can see here. Where's my camera? You see there's a little clip, and there's a male and a female, and it's like a little plug. And this is 3 millimeters tall, which if you measure a knot stack, it's actually 5 to 6 millimeters. And it's like 7 millimeters across. So it's like a little clip that sits on the bone. Serves 2 purposes. One, speed, like not having to tie knots if you do a ton of suturing. And then also the ability to tension all at the same time. And I also think, I know you guys have said you haven't had any cut out of bone. I occasionally do, I will cut a few out. I'm sure it's because of my technique. But I do think that in soft bone, by having that edge, a piece of plastic while you're tensioning, it will function similar to the plugs that Mark used in the past on every cup. And so the tension that you want to create with this is, I mean, you could go way more than what you need, but it's just more controlled. And just really the whole basis of this idea is speed, right? Like try to make transosseous technique faster and easier so that surgeons will adopt the technique. And so what you have is just this plug, this male and female end, the sutures come through, and then you link it to the tension device, you tension it, you clip it, you lock it, and then you cut it and you're done. And so I've been working on this for like a year and a half. I just got the functional prototype today. So we're hopefully going to be able to put these in a couple people this year, get it FDA approved.
Oh, easy, man. Just commercialize it. Come on.
Yeah, we're close, dude. It's not, I mean, we're not that far away. Like the FDA, because the thing is that the clips, this is like a 510K, right? So like there've been many clips that have been made in the past, but there have been no clips made for like arthroscopic sutures for this level of, so we were able to patent the idea and the concept. But in terms of getting it FDA approved, it should be pretty quick. All we have to show is that our not pull out strength is good. So for me, I'm like Brett, I like to do just simples, right? Like just simple, but I'll do like 4 or 5 pieces of suture tape. And I've actually got a value company that can get you guys tape cheap if anybody wants to get really cheap tape. Because tapes actually, they're not as cheap as you think. Sometimes they'll charge you $30, $40 for a piece of tape if you're not careful. Basically, I'll pass 4 or 5, sometimes even 6 pieces of tape through a single tunnel and just do simples. And if I've got a massive cuff, I'll do 12 and just do 12 cerclages. I've just gone to just doing simples. But it just takes time for me to just go up and down the line tying like 10 or 12 knots on a big cuff. So I figure you take them all at once, you can clip it. And then I've actually got another design for a suture that's specifically designed for tunneling, where you basically have 1 limb of suture that spreads out into 6. So then you're just funneling 1 limb of suture in through the tunnel, and then you pass your 6, so it's like a triple loaded anchor. Then you would go 6 to 1, clip and lock. Just simple. And it's just a way to basically add to Brett's device to make it a little bit faster, a little bit easier.
Cool. Thanks for that, Kevin. And I'd like to just point out a couple of things that he talked about. I mean, there's an order of magnitude cost reduction possible with SCR. You rarely see that in the device world, where you can have literally an order of magnitude reduction. Maybe there's still a few pain points there surgically, but that's very interesting to me. The pain reduction as well that you noted about, I've heard that as well from anchor companies, that even the soft anchors medially, anything, the hard anchor on the medial side causes the most pain. And even with my hybrid techniques, 1 anchor laterally, I don't see a big introduction of pain, but we definitely see reduction of pain with less hard anchors as the medial row.